Welcome to the deep dive. Today, we're tackling hypertrophic obstructive cardiomyopathy, or HOCM. Think of this as your sort of streamlined guide. We want to get you the key facts fast.
Exactly. HOCM, well, fundamentally, it's a genetic issue, often runs in families.
Right.
And the hallmark is this unusual thickening of the heart muscle. Crucially, it can block blood flow.
Block blood flow and hinder pumping. Okay, let's unpack this a bit. So it's genetic, makes the heart muscle thicker.
Yep.
Our sources say this thickening comes from defects in the genes for the heart's contractile protein.
That's right, the building blocks, essentially.
And it's a type of cardiomyopathy, so a disease of the heart muscle itself, not like blocked arteries.
Correct. Myocardial disorder.
And it's a big deal because, well, it's a known cause of sudden cardiac death, especially in younger people.
It is, tragically. And just for context, there are a few main types of cardiomyopathy: hypertrophic, like this one, dilated, arrhythmogenic, restrictive, and some others. But with HOCM, we're really focusing on that left ventricular hypertrophy, the LVH.
The main pumping chamber thickening?
Yeah, and problems with the heart relaxing and filling, that's impaired diastolic filling.
Right.
And sometimes issues with the mitral valve, too.
And it all circles back to those, like, genetic hiccups, mutations in beta-myosin heavy chain, troponin.
Exactly. Beta-myosin heavy chain, myosin-binding protein C are common ones. It's like a typo in the instructions.
Leading to disorganized muscle cells and that LVH. Okay, so let's get into the nitty-gritty. What exactly is going wrong inside the heart?
Okay, so here's where it gets really interesting. We've got this abnormal thickening, mainly in the left ventricle, especially in the septum, that wall between the ventricles.
Right, the interventricular septum.
And that thickening can actually block blood from leaving the heart when it contracts during systole.
An obstruction.
Yes. And this blockage, plus the Stairsman muscle, means the ventricle struggles to fill properly, too.
So pressure builds up inside.
Exactly. Pressure goes up and less blood gets pumped out effectively. Cardiac output drops. Think of it like trying to push water through a suddenly narrowed pipe.
Yeah, okay. And it's not just a plumbing problem, is it? You mentioned arrhythmias earlier. Our sources highlight that risk.
Precisely. That disorganized muscle structure, it can really mess with the heart's electrical signals.
Disrupts the normal pathways.
Makes it prone to irregular rhythms. That's a major concern.
And those key genes, again, were beta-myosin heavy chain and myosin-binding protein C.
Those are the big players, genetically speaking. And a really key point to remember, HOCM usually causes diastolic dysfunction. The filling phase is the problem.
Okay, diastolic dysfunction. Got it. So we know the what, but why does this happen? What's the root cause?
Well, primarily it's those genetic mutations we keep mentioning. They're the main driver.
The inherited ones.
Yes. Alterations in the genes coding for those heart muscle proteins. Now, the sources do mention it can sometimes be acquired.
Like from high blood pressure or aging.
Exactly. But really, for classic HOCM, the focus is squarely on that inherited genetic piece.
Which makes sense when we think about risk factors then.
Yeah.
They seem to directly mirror the cause.
Absolutely. The biggest risk factor is simply having a family history of HOCM.
Suggest those genes are present.
Right. While things like aging, hypertension, maybe some metabolic disorders, even chest radiation are sometimes mentioned.
For understanding HOCM itself.
It's family history and genetics you really need to focus on.
Okay, crystal clear.
Yeah.
So how does this actually show up in a person? What are the signs, the symptoms?
It's quite variable, actually. Some people, no symptoms their whole lives.
Really? Asymptomatic?
Yep. But when symptoms do appear, they often link to exertion.
Like chest pain during activity.
Yeah.
Angina.
Yes, exertional angina, shortness of breath when active, unusual fatigue,
Okay.
fainting or nearly fainting, syncope, that's a big one, especially after exercise in HOCM.
After exercise, that's specific.
Yeah, due to that outflow obstruction getting worse as the heart rate comes down, maybe. Also palpitations, arrhythmias.
And unfortunately, sometimes sudden cardiac arrest is the first sign.
Rarely, but yes, that's the most serious presentation.
So what might a doctor pick up on examination? Our sources mentioned a jerky pulse.
Yes, that's one finding. A jerky pulse character. You might also see prominent A waves in the neck veins, the JVP.
Okay.
And sometimes feel a double beat at the apex of the heart.
A double apex beat?
But the really classic thing is the murmur, an ejection systolic murmur.
Right.
And what's key is how it changes with maneuvers. It gets louder with Valsalva straining.
Like bearing down. less blood returning to the heart.
Exactly. And it gets softer when someone squats down.
Squatting increases blood return. Okay, that's a great clinical clue.
It really is. And this altered flow can also cause the mitral valve to leak, sometimes mitral regurgitation.
Our notes are quite detailed here. Anything else on examination?
Oh, yeah. You might feel a really forceful apex beat, maybe that double impulse, especially with significant outflow obstruction.
Okay.
The pulse itself might feel quite quick on the upstroke and downstroke.
Rapid rise and fall.
That prominent A wave in the JVP suggests the right ventricle is stiff, having trouble relaxing.
Reduced compliance.
The murmur itself is often loudest at the left sternal edge, might radiate,
Left side of the breastbone.
and an abnormal blood pressure response during exercise, like a drop when standing up and exercising. That's another red flag.
Interesting.
And don't forget atrial fibrillation. AFib is actually more common in HOCM, maybe around 20% of patients.
Okay, that's significant.
Other things, maybe a harsh quality to the murmur, an extra heart sound, the S4 gallop. Sometimes signs of heart failure if it's progressed.
Wow, okay. Lots to look for. So if HOCM is suspected, what's the detective work? How do you confirm it?
The absolute cornerstone is the echocardiogram. The echo.
Ultrasound of the heart.
Exactly. Lets you see the heart muscle, measure the thickness.
Look for that ASH asymmetric septal hypertrophy.
Precisely. See if the LV cavity is normal size, which it usually is. Check systolic function. It's diagnostic.
And cardiac MRI.
Sometimes MRI is even better for detail. Yeah. Assessing the full extent.
What about the ECG?
ECG is vital too. Often shows signs of that left ventricular hypertrophy.
Makes sense.
You might see nonspecific ST or T wave changes, sometimes inverted T waves, deep Q waves.
EQAs.
Yeah. And sometimes it'll pick up atrial fibrillation if it's present.
Now, our sources had a mnemonic for echo findings. MR-SAM-ASH. Can you break that down?
Yeah, it's pretty handy. MR is mitral regurgitation, the leaky valve we mentioned.
Okay.
SAM is systolic anterior motion of the mitral valve. That's where a leaflet gets pulled into the outflow tract during contraction.
Worsening the obstruction.
Exactly. And ASH is that asymmetric septal hypertrophy, the uneven thickening of the septum. MR-SAM-ASH.
MR-SAM-ASH. Got it. What else? Any other tests?
Sure. A Holter monitor wearing a continuous ECG recorder for 24 or 48 hours.
To catch arrhythmias.
Right. Or longer ambulatory ECG monitoring. A chest x-ray might show an enlarged heart, but it's variable.
Less specific.
Cardiac MRI gives great detail on LVH, severity, function, even tissue characteristics.
Okay.
Cardiac catheterization is more invasive, but directly measures pressures, the outflow gradient, checks coronary arteries.
When might you do that?
Maybe if diagnosis is unclear or before surgery. Exercise testing helps assess symptoms and that BP response. Genetic testing can find a mutation in about 60% of cases, usually those sarcomere genes.
Useful for family screening too, presumably.
Absolutely. Endomyocardial biopsy is rarely needed, mostly to rule out other things like amyloidosis, BNP, blood tests, not that helpful for HOCM diagnosis itself.
Okay.
And maybe metabolic screening in infants or kids with unexplained hypertrophy.
Right, a broad workup sometimes needed. So once you have the diagnosis, what's the plan? How is HOCM managed?
Okay, management goals are basically twofold. Ease symptoms and critically prevent complications like sudden death.
Makes sense.
Medications are usually the first step. Beta blockers are very common.
Why beta blockers?
They slow the heart rate, reduce how forcefully it contracts, which can lessen the obstruction in symptoms.
Okay.
Calcium channel blockers, specifically verapamil, can also help by improving how the heart relaxes and fills.
Better diastolic function.
Exactly. And antiarrhythmic drugs like amiodarone might be needed for rhythm problems.
And importantly, there are meds to avoid.
Yes, definitely. Nitrates, ACE inhibitors, certain inotropes drugs that increase contractility are generally avoided because they can actually worsen the outflow obstruction.
Good to know. What if meds aren't enough?
For significant obstruction or persistent symptoms, you might consider a more invasive option then.
Like surgery.
Yes, septal myectomy is the classic surgery where they surgically remove a bit of that thickened septum.
To widen the outflow tract.
Correct. Or there's alcohol septal ablation, injecting alcohol via a catheter to cause controlled damage and thinning of that area.
Less invasive, presumably.
Generally, yes. And then there are devices.
Like ICDs. You mentioned sudden death risk.
Exactly. Implantable cardioverter defibrillators, ICDs, are crucial for patients identified as high risk for sudden cardiac arrest.
They shock the heart back to normal rhythm if needed.
That's the idea. They monitor constantly. In some specific cases, a dual-chamber pacemaker might also be considered.
And lifestyle.
Important too, avoiding really strenuous competitive sports is usually advised. Managing blood pressure well.
Okay. And one point here, routine antibiotics for endocarditis prevention.
Ah, yes, that's changed. It's no longer routinely recommended for most HOCM patients.
Good update. So key management pillars are rhythm control, reducing that outflow gradient with meds or procedures, anticoagulation if AFib develops, and ICDs for high-risk individuals.
That sums it up well. Rhythm, gradient, anticoagulation, ICDs.
So what's the long-term picture? Prognosis, complications?
It's quite variable, honestly. Many people live pretty normal lives, minimal symptoms.
That's good to hear.
But others can develop significant heart failure over time, or atrial fibrillation becomes a problem, especially as they get older.
And the sudden death risk is always there.
It's a concern, yes, especially in younger people where it might be the first manifestation. Intense competitive sports definitely increase that risk.
Are there predictors for a worse outcome?
Factors like being diagnosed very young, a strong family history of severe disease or sudden death, and just how thick the heart wall gets, greater thickness, seems to correlate with higher heart failure risk later.
But overall mortality has improved.
Yes, significantly. With better diagnosis and management, including ICDs, mortality rates are generally quoted around 1 to 6% per year now, much better than historically.
That's encouraging. What are the main complications to watch out for?
Well, the arrhythmias we've discussed, AFib, ventricular tachycardia, sudden cardiac arrest, obviously, progressive heart failure, that mitral regurgitation can worsen, infective endocarditis, though less common now maybe with prophylaxis changes, stroke or embolism, especially if AFib isn't managed, and potentially increased risks during pregnancy.
A lot to consider. Sounds like HOCM could be mistaken for other things, too. What's on the differential diagnosis list?
Absolutely. You need to think differently depending on the age. In infants or young kids with LVH.
Think congenital.
Yeah, congenital heart defects, inherited metabolic or neuromuscular diseases, specific syndromes like Noonan's or Friedreich's ataxia.
Okay. And little older kids or adults.
Other familial conditions, maybe mitochondrial disease. Anderson-Fabry disease is an important non-sarcomeric cause of hypertrophy. Wolff-Parkinson-White can sometimes present confusingly.
And then just broadly, other things that cause LVH.
Right. Simple obesity can cause some LVH, athletes' heart physiological hypertrophy, pathological things like amyloidosis,
Amyloid.
pheochromocytoma, though rare, other cardiomyopathies restrictive or even dilated sometimes, hypertensive heart disease is common, and aortic stenosis, valve narrowing.
So a wide differential. How common is HOCM?
Estimates in the UK put it around 1 in 500 people.
Wow, that's actually quite common.
It is. It's the most common genetic heart disorder with that autosomal dominant inheritance.
Meaning a 50% chance of passing it on.
Typically, yes. Symptoms often start showing up in adolescence or early adulthood, say second or third decade.
And as we keep saying, a leading cause of sudden cardiac death in the young and in athletes.
That's its most feared aspect, and some data suggests it might be slightly more common in men and perhaps in people of Afro-Caribbean descent.
Okay. Given it's genetic, family screening must be huge. What about assessing risk within families?
It's absolutely crucial. Sudden death is the big worry, even if someone feels okay. ICDs work, but figuring out who needs one isn't always simple.
What are the high-risk signs for sudden death?
Things like a previous cardiac arrest or sustained VT, unexplained syncope, especially if recurrent, that abnormal BP response on exercise we mentioned, massive LVH thickness, family history of sudden death is also weighed heavily.
But genetic testing isn't always the full answer.
It's not always practical or might not find a mutation even if HOCM is clinically present. So family screening often relies heavily on good old-fashioned pedigree analysis, ECGs, and echocardiograms for relatives.
So check the first-degree relatives, parents, siblings, children.
Yes, regular screening is recommended for them. For children of an affected parent, screening usually continues periodically until maybe age 20 or so, and it's less likely to develop if it hasn't already.
So what does this all mean? It really paints a picture.
It does. It highlights this really complex link between our genes, how our heart is built, and the potential for quite serious outcomes. It underscores why careful diagnosis, risk assessment, and ongoing management are just so vital.
It's a really comprehensive overview of hypertrophic obstructive cardiomyopathy. Just to recap quickly, it's genetic, causes heart muscle thickening, can block blood flow. Presentation varies a lot. Echo is key, remember, MSRA.
Mitral regurgitation, systolic anterior motion, asymmetric hypertrophy.
Right. Management using meds, sometimes procedures or devices like ICDs.
Yeah.
And family screening is super important.
Absolutely.
We hope this deep dive helps you, especially if you're studying for exams. For more resources, do check out PassiveMSRA.com and freemsra.com.